How will the effects of ongoing healthcare reform? Now let's talk about, you're talking about the 800-pound gorilla in the room. Let's talk about the 2 million-pound gorilla, which is the Affordable Health Care Act. Right? That's been passed. The Supreme Court's ruled on it. It's the law of the land, likely to go forward. How is this going to impact, we'll start with Jeff, the coverage for cancer in terms of immunotherapies?
Well, to me, Obamacare consists primarily of expanding the equivalent of Medicaid to a larger chunk of the uninsured population, which is not a bad thing, it's a good thing. This country has a huge proportion of uninsured folks, I'm sure the highest proportion in the civilized world, or the advanced world, the industrialized world. So I think it's a good thing that fewer people will be uninsured. That means they'll be able to come to Moffitt, which has some modest proportion of charity care, but most everybody we see has some insurance. It means we'll be able to see more patients, get them on better treatments, get them on trials. So I think that's a plus. And there'll be some guidelines, as there are, for can you use IPI, can you put them on a trial. One would hope there'll be reasonable guidelines. So I don't have a problem with that.
What about ACOs? Organizational models such as that, are they feasible for oncology reimbursement?
So I think I would agree with Jeff. I think the thing that we're going to see most immediately is the health insurance exchanges and the expansion of Medicaid, which will provide a large number of patients who previously had no health insurance, some health insurance.
Yeah, the number's 40 million or so.
The truth of the matter is that we actually don't really know how cancer patients are going to be taken care of within that construct, because the benefits design is a very basic benefits design. I mean, it's better than nothing. But I think the question is, so how do you take care of cancer in that universe? I assure you, they would pay premiums in the health information exchanges for many, many years for how much it costs for one cycle of one treatment of Provenge. So, I think it's a little bit unclear how cancer care is going to happen in that world. Now, that's the immediate change. But of course, the long-term change is going from fee-for-service, paying for transactions, to paying for value. And that's actually a very interesting area. When I was in practice a few months ago, I thought there's no way that ACO is going to happen. And you know what? Now I think they're going to happen.
Now they're going to happen.
Now I think they're going to happen.
But what about, I've always worried about this, and I'm not alone, what about innovation? I mean, part of the cost, we're talking about the large cost per year for some of these drugs, part of that's just R&D. And if you start to pay for exactly what the cost of the drug is to manufacture, then you haven't covered the R&D and you freeze the system in place, no?
So I think that we talked about the possibility that up to 30% might be waste. I've always thought of that as the pool of money to pay for innovation. That's my own mind. I don't think Aetna has any perspective on that, but I've always thought, well, that's a lot of money, if we
Good luck carving the 30% out. Though.
Well, so here's the challenge, right? So who's going to be the ACOs, right? So we've got integrated delivery systems. There's not many of those, right? We got Mayo Clinic and Geisinger and then we got a lot of hospitals who aspire to transform themselves to be ACOs. And there's a lot of reasons why it's hospital systems, but let's just accept the fact that hospital systems are the predominant player in this area. They're going to have to undergo change. They got to really change the way they're thinking about care. So keeping hospital beds full is no longer your primary driving force. Negotiating a good price for that hospital bed, it changes. It changes, and so if we can execute that change, that's where the money comes from.
What about Obamacare in terms of its impact on immunotherapy specifically? I'll ask you two guys. Is it going to help or hurt the implementation of immunotherapy and the R&D?
Well, I mean, I think this is a dynamic area. This is a phased healthcare reform, and as Mike and Jeff have said, the first phase is that we're going to get greater access to care for patients. Now, these are expensive therapies, and to what extent, the basic plan, if you will, the Medicaid plan covers an expensive therapy, I think remains to be seen. But I'm encouraged. I'm encouraged in that ideally, for the patients that we think are going to benefit most from immunotherapy, they're more likely to have some insurance to allow us to treat them.
What about smaller practices?
The benefit to society is that we treat the right patients with the right drugs, that we avoid the waste. So the patients that have, some coverage now that can get that, we're going to, we'll be able to increase that, enrichment strategy.
Is the way to carve out your 30% waste to that you could put it going forward? Is that going to be at the cost of small practices versus large practices? Large practices that achieve economies of scale?
Good question. I'm
Thank you very
not
much.
a
I
private
thought of it all.
practice. I'm not a private practice doc. It's not something I've thought extensively about, but I don't see that point. I think that if you're practicing value medicine, you should be able to survive in a small group or a large group. Again, it comes back to how much we waste. It's unbelievable how much we waste.